been looking at your programme. In fact, we've both been looking
Yeah.
at your programme over the last few weeks to see how we could, A, replicate it, and B, dare I say it, improve it.
Yeah,
Because we see it as the model globally, actually,
right,
for the training of young epidemiologists of the future. So we're absolutely on side, and we'll be coming to see you anyway about it. But that's another story.
Right, because our school also, I mean, we've been producing thousands of epidemiologists, but I think it's necessary but not enough. And it's necessary for the field work, and for example, what we need now in, to deal with the last mile of Ebola will require very haute couture, I call it epidemiology, really detective work in the field. But when you think of the big global health threats, we need more than that, and we need to bring it all together. And that schism between, public health, the world of prevention, and clinical medicine and science, I think that is one of the big, obstacles that we have to overcome.
Yeah, it's something I've certainly talked on regularly with a title of public health, clinical medicine, and the rest of health being divorced for too long.
Yeah.
And I think it has been. But Tom, fear not, it is the model that we hope to follow and emulate. Peter, everybody likes to kick Geneva and WHO, and I think it's been unhelpful in many times. But nevertheless, they are the leading authority for global public health. Where is their future, do you think?
Well, the world needs WHO. Let's to start with that. And I think the last thing we need would be to invent and set up yet another organization just to deal at the global level with emergencies. But we need a much better WHO. That's for sure also. One that that has the capacity and the courage to intervene where epidemics arise, because that's a global public good. And where we have a strong central body, entity, whatever you call it, within WHO that is protected and that can be deployed together with others, with CDC and with whoever, and of course the countries, and can be deployed immediately. And I'd rather be accused of overreacting than of underreacting. And
but these sound good, but the truth is it'll be protected for a while until the Ebola becomes a distant memory, particularly to those in Geneva, Washington, London, Paris, etc. And then it will be reduced. So that has been the track record over the last 20 years.
Yeah, and actually I think that many countries don't want a strong WHO. They don't want multinational, multilateral institutions. But I think that with growing awareness, I think, of the danger and the risk of epidemics, I think that the understanding, for the time being, as long as Ebola is in the news, and then the next epidemic, there should be a protected budget in WHO associated with a strong reform movement. And one of the problems is the WHO offices in countries who are weak, and some of the regional offices. The regional office in Africa should be the strongest of all, because that's where the biggest health challenges are. It is the weakest. And so we need to find a way of strengthening that, but also no compromise on quality and on, and where the health of the people should come first.
But Tom,
I was seconded to WHO for 5 years, so I've worked with them, and I don't think you should just whole cloth say it's a problem. There are also terrific people within WHO who work very effectively, who are very knowledgeable. The challenge is, as with people, as with organizations, your greatest strength is often your greatest weakness. With WHO, the fact that they do have the political buy-in of countries is also their greatest weakness. So how do you insulate from political influence the core technical issues that need to happen, including selection of regional directors, selection of country directors, staff decisions, and speaking truth to power and telling it like it is.
Would you keep the regional offices?
I think they've either got to be greatly improved or their authorities have to be greatly reduced.
Yeah, and this was a summary previously, either completely decentralized to very strong regional and national offices, or centralized. But the current hybrid doesn't quite get there either. Just to put on the record, I am a very, very strong believer in global bodies, and an absolute believer in WHO being strengthened so that it can serve its purpose. Because I think otherwise a fragmented healthcare system globally would be far, far worse.
Yeah, but I think that in case of epidemics, you need a global approach, and it can't be, I mean, of course, the action is on the ground, one country or multiple countries, regional, but it is a threat to the rest of the world. And again, coming back to the notion of a global public good, that's why you need a central type of body that can intervene and that can do the analysis, etc. And not decentralized. I believe that for health systems, strengthening and so on, I think that should be decentralized, and that's something that has to be built up country by country. But epidemic preparedness is something else.
I agree with that. However, I don't think we should expect WHO to be able to do it all.
No, no,
right?
no, no.
It needs to have a coordination and an intelligence function, greater
Yeah.
capacity than it has now, more ability to reach into regions and countries.
Yeah.
But we need to build on entities like the Global Outbreak and Response Network
Yeah.
to bring in MSF, to bring in London School, to bring in CDC, to bring in other partners. The African Union has been phenomenal
Yeah.
in West Africa. They've got 700 people there now. Close to 100 of them have been trained 2-year epidemiology
But I think
programs.
I'm
So
right.
they'll make a difference.
Correct me if I'm wrong, Tom, but I think I'm right in those so-called non-state actors, which is not a term I like, but don't have any voice, certainly not on the executive board of WHO. They have no voice within the governance structure currently.
At least they should have a voice in how to get things implemented and done, and they should be determinative in making sure it happens right.
Okay, I'm going to open it up now. Questions on any subject, price of bread, epidemics, global governance. Yeah. If you could just introduce yourself quickly and then to whom you want to.
Ilya Kasik. I'm global shaper for Moscow Hub and board member of Mantix Diagnostics. We have actually developed a point of care plug-and-play device for blood tests, which give laboratory quality. So we think that technologically we are there for the rural areas of the emerging markets. The technology is there. We don't need, as Thomas said, the couriers, the roads. So the cheap technology is there. We can do it very cheaply. Now, then the second problem we had is the distribution partner, because in these places it may not necessarily be the healthcare partner. It might be, food distributor or even churches, organizations like that. What we're struggling with is that how to educate the population that they actually need to do those regular checks, how to raise awareness among them, because it's just something they have never done before. And that's something we cannot realize, actually. We cannot get it.
I think this is a major problem because when the WHO, and I don't just talk about the WHO, it also applies to all of our organisations, was set up the state itself was the deliverer of all things in many, many countries. That's no longer true. How do we reach out, Peter, how do we reach out to the non-state actors, the churches, the community leaders, the society, which is often actually delivering healthcare with nothing to do with governments?
Well, in the case of AIDS, this has always been a given. Not always, in the early days, but that was because the state didn't want to be involved with AIDS. So we went to the non-governmental sector, or whatever, civil society, business, what have you. And it has not been without its problems. But there you build local coalitions, and in some cases that's more like church-affiliated organizations that are providing healthcare. In others, it's more for-profit business. It can be in the case of epidemics, MSF, just as Tom says. But I think that that's something that has to be, organized within countries. And then I think at the global governance level, we have the example of the Global Fund, where you have representatives, in this case of people living with HIV, NGOs and so on, and business. I think it's not impossible. And it's one of the issues that will be debated in WHO also, and I think that WHO should open up itself as well for that, so that you have a very pragmatic approach to to delivery, to setting policy. Although I know at the end of the day it's the state that has the responsibility for policy, for health security and so on, but it cannot deliver everything.
And also, the state has a facilitative role for new technology.
Yes, yes.
We've seen all over the world totally inaccurate technologies marketed to the poor, who pay top dollar for them and are not benefited by them. So the combination of technologies that lead to real health improvements that people can recognize, and a government infrastructure that, without impeding innovation, facilitates
Yeah.
the delivery of reliable services in whether it's public or private.
Yeah.
Point.
Thank you. I'm Gary Cohen with BD. I'm also a member of the board of the CDC Foundation. Simple question. You mentioned Uganda and Kenya, Ebola outbreaks were quickly brought under control. Nigeria, during this recent outbreak, I think in large part because CDC already had emergency operation centers there, partially funded by Gates or largely funded for polio, quickly brought under control, could have been a disaster. What needs to be done so Guinea, Sierra Leone, Liberia goes out of control? What are the fundamental things that need to be put in place? Who should fund it and who should implement it?
Tom, do you want to start?
I'll start. Get to zero, stay at zero. Get to zero by tracing every single chain of transmission, and that is the traditional epidemiology. It's a public health response. That means putting public health teams in all 62 of the subnational areas, breaking the urban areas into wards or units and working really intensively so that every single case is tracked. In September, October, it was impossible. There were so many cases, it was impossible. But now, with the waters receding, you can see the streams, and then you can stop the spread. But that also means going into every forest community of Guinea to identify whether there are cases. That's where it came from. That's where it's got to stop. And that's going to be very challenging. Dealing with resistance means, on the one hand, providing good, sensitive, timely, respectful services. On the other hand, dealing with community perceptions or misperceptions of causes of illness. Having public health structures, having laboratory capacity, having treatment capacity, burial capacity when needed in every single place. We've seen tremendous progress in Liberia in the past couple of months. We are hopeful that we can see that kind of progress in Sierra Leone. But Guinea is a cautionary note because they've oscillated in cases.
Yeah.
You let up your guard and it comes roaring back.
There's nothing there that I would absolutely endorse all of that. The only thing I would add to that is your only opportunity to change this and future epidemics in a different way are to conduct research during this epidemic. You cannot work out how to treat an individual with Ebola unless you do that research within the context of an epidemic, because there are no human cases outside an epidemic. You can't work out truly whether a vaccine is both safe and efficacious and effective unless you do that research during an epidemic. And this is a unique opportunity to ensure that we do everything that Tom just said, but in the inevitable future epidemics, that we do not have no access to decent diagnostics, decent treatment, so we change the communication around coming into a treatment centre, and we have vaccines that, at the very least, would mean that no healthcare worker dies of Ebola again. So I would just add that. Peter, do you want to add anything?
No, I agree.
Yeah, and then
Seth Berkeley Gavi, a comment and then a question. I couldn't agree with you more about ring fencing, infectious disease, funds. You know, evolution is going to occur. I know some people in my home country don't believe that, but evolution is going to occur. We're going to continue to have new bugs, new infectious disease outbreaks, and once and for all, and you're absolutely right, the history is over 20 years as we go up and down, we need to have that adequately resourced. We need to have the laboratory facilities, et cetera. The question for me is, in development speak, we're about primary health care, we're about primary education. Critical to this is getting graduate education, strong universities, strong research institutions. So Mali is another country that, you know, has a vaccine testing unit that has a really good set of scientists, and they played very importantly in this. So how do we shift the mindset to say, you know, yes, we have to have primary healthcare, university healthcare, et cetera, but we also need to have in parallel very strong local institutions with high-level people and the incentives in place, you know, to be able to keep them, because otherwise, you know, we're going to fly in and fix things and fly out again, and that's a problem.
yeah, huge. Peter, do you want to start? Then I'm sure.
Yeah,
Tom
I think this is a very important issue from the perspective of in the development world. When it comes to education, was first everybody primary education, and then secondary education, and tertiary education, and this kind of institution is kind of a private luxury type of thing, and particularly for sub-Saharan Africa, as long as there aren't institutions that are producing the intellectual property lawyers, the engineers, not only, I mean, all the other professionals and so on, it will risk to remain an extraction economy or, you know, cash crop economy, and won't be ready. And I think the example of certainly East and Southeast Asia is that shows that the other way is possible. And so we need to invest in that. you know, just at the same time as we invest in health system strengthening and so on. So it should become integral part of the, you know, international development agenda. I couldn't agree more.